Hello, I'm Precious, and I will be discussing the epidemiology of diabetes. My poster is going to cover the background information, some statistics, and diagnostic tools. And I'm going to use three hypothetical situations to show the differences in diabetes management. So, just to give some background, this is one of the most common non communicable diseases in the world. There are six types: type 1, type 2, gestational, drug induced, monogenetic, and diseases of the exocrine pancreas. So, one of the major primary symptoms of diabetes is an altered state of glucose regulation. Based on the severity of the disease, or the time that you realize that you have it. Other symptoms can include things like blindness and ultimately death in the worst case scenario. The International Diabetes Foundation analyzed um, some diabetes cases from 2019, which is the most recent data I can find on the prevalence of diabetes. And they identified 463 million adult cases globally, and they considered adults to be anyone aged 20 to 79. And a little bit more detail about those statistics is in the table one and figure one at the bottom of my poster. In summary, though, the region that had the highest prevalence was Middle East and North Africa, with 12.2 of that region having 12.2% of that region having diabetes, and the lowest prevalence was identified in Africa. So, just to explain these statistics, when I was looking for information about the breakdown of diabetes by race, I didn't see any information that can identify that globally. It was available for local um, public health information and even for nationwide public health information, but on a global scale, the IDF decided to break it down into 7 regions. And the regions are not based off of the continents, they're based off of the classification methods that IDF used. So, as you can see, Middle East and North Africa are considered one region. And even though North Africa is a part of the continent of Africa, the the different trends or the similarities in terms of the religion between the Middle East and the Northern African regions probably influence their diet practices, and just cultural differences or similarities would cause some groups to be considered one region while others aren't. And as I mentioned before, there are 7, and I have them listed in table 1. So it has the information on the amount of people in that population in 2019 that was diagnosed with diabetes, and what percentage of that population those people accounted for. And I will note that 90% of the diabetes cases are type 2 diabetes. So that's one of the most common ones. And type 1 and gestational are also common ones. So, in terms of the epidemiology of this disease, the expanded risk factor model helped in highlighting the ways in which different factors can affect your susceptibility and vulnerability to the disease, and how those factors need to be considered when doing any type of analysis or evaluation in the risks that can lead to that. So I mentioned earlier that while diabetes is not a contagious disease, there are family history or genetic activity that can influence individuals' susceptibility to it. So, Um, if one of your parents or grandparents has type 2 diabetes, that increases your chance of having it, and that's considered a risk in this model. And there are also type 2 diabetes genetic type 2 diabetes genes. So just different genetic factors influence your susceptibility to diabetes. Social and environmental factors are also listed in this area. I have the fetal and adolescent undernutrition factor. So, um, based on your diet when you're younger, and obviously that's a diet that you personally or patients don't have control over, um, the being undernourished can alter your genes and then increase your risk of developing some type of diabetes later on in life. Overnutrition and different activity and dietary factors can also influence that. Comorbidities and living conditions. I noted that also there are lifestyle choices that influence your susceptibility. Similar to fetal and adolescent undernutrition, there are some living conditions that patients don't have control over, and they also increase the risk of any disease, including diabetes. So there are other cases, which is pretty common actually, where the choices that you make in terms of your diet habits or activity levels can lead to diabetes. And it's something that is considered a choice, so you have more control over that. And then there are things in the economy that also affect um, diabetes susceptibility, but it's considered a risk also due to the impact it has on the economy as a whole. So when it has to do with your personal finances and your ability to work and the way you're able to support your family, that is one example. But then there are also healthcare costs and resources that come into play as well. And I used the different factors to kind of make my own risk factor model. It's not as nice as the one in the textbook, but just to show how the type of diabetes you have is one factor that already makes diabetes management complex, and then there are just other factors that people are not in control of. So, in terms of diagnostic and screening tests, these are used in diabetes to obviously to diagnose it, but also to help in just monitoring blood sugar in general, and help, especially is helpful in asymptomatic cases or in cases where the blood sugar is very high and borderline diabetes. So it's a nice area to intervene before it progresses into type 2 diabetes, for example. And the different diagnostic tests include fasting plasma glucose tests, oral glucose tolerance tests, and the hemoglobin A1C test, which is the test that I'm going to focus on. Um, so the way the A1C test works is that it measures accumulated blood sugar levels from about 3 months prior, 2 to 3 months prior. The results of the test will put you in either a normal blood sugar category, a pre-diabetic category, or identify you or and your blood sugar as a diabetic case. And these are the percentages noted in this table, table 2. And some things to consider with this test is the fact that it does not test fasting glycemic levels, as I mentioned. It's an accumulation of blood sugar from about 3 months prior, which is helpful in determining your actual HA1C activity, as opposed to determining how your daily blood sugar or your blood sugar for just like a shorter period of time, like 1 week, affected the H1AC levels in your HbA1c levels for a particular patient. And in terms of specificity and validity, the test is not as accurate in pregnant women and for individuals with certain hemoglobinopathies. So that includes sickle cell gene carriers and things like that. And I'm going to discuss the way the A1C test affects um, individuals when I get to the hypothetical situations that I noted earlier. So, in terms of diabetes treatment and management, um, the expanded risk factor model highlights the different risk factors that can impact the susceptibility and vulnerability of patients that have diabetes. And those complex risk factors and just the variation in humans in general also further complicates management and treatment options. And when I say that it complicates it, it makes it more difficult to use one method to treat one person or even one community. It really does require individual evaluation. Um, and uh, the examples I have here are some medical devices and medication, including insulin therapy medication and devices to monitor blood sugar levels. And when doing interventions, whether it's educational, whether it's training or whatever, it has to be relevant to the area and the culture of the community that you're in, similar to the way IDF groups the Middle East and North African region as one region, due to the fact that it made sense. It made more sense than to just make make an assumption or make a suggestion based off of the whole continent of Africa, because there are individual differences um, within continents, within countries, and within states. So those are things to consider when designing intervention programs. And the individual the individualized nutrition relates to those things like undernutrition or overnutrition, and whether patients are also dealing with comorbidities that can also impact their ability to regulate their blood sugar. So, the examples I have at the top are three patients, and they all use the A1C test to diagnose themselves potentially with diabetes. So the first example, this woman had type, she had a blood sugar range that was 6.5%, um, which is in the diabetes category. And they had to do follow up genetic testing to confirm that it was actually type 1 diabetes. And immediately they started putting her on insulin therapies. So she was injecting insulin to help with the decreasing insulin due to the decreased capacity of her beta cells. So she continued to actually use the A1C test to monitor her blood sugar. And there were obviously other management things that she did, but that was the way that the A1C test was able to help her. And then there was a situation where there was a potential gestational diabetes situation. She used the A1C test and she was borderline diabetic. She was 5.9%, so she was considered pre diabetic. But as I mentioned earlier, this test is not the most accurate for pregnant women, but it did help in highlighting the fact that she did need to work on her general sugar intake and just monitor the way she was eating in general, just due to the fact that she was pregnant and, there were she's caring for herself but also a baby, so she monitored that closely, and she also worked with the healthcare team that could address her specific needs. And they also educated her family to get help from them as well to monitor her when she was at home. And she was able to lower her blood sugar um, a little bit, but the main key was that it didn't progress to diabetes. And then there is an example of a man that used the test, and his blood sugar was fairly high, and it was at the 7% range. So he was considered diabetic. He used self management tools, but he also had different medication that he was taking due to the fact that he had hypertension, which obviously is a comorbidity. So these are the different cases that patients can be dealing with that can impact the way that they manage diabetes and if it's able to be prevented. And in the type 1 diabetes case, that is a genetic disorder. And there is research being done into how it can be prevented, but there currently is not any cure. So, in conclusion, I'm just going to highlight the fact that there is a concern with diabetes as the global prevalence continues to rise. The research has shown how the different factors impacts patients' ability to manage it, and um, in terms of health policy, it's related to health equity and also related to the environmental factors I discussed earlier. The Affordable Care Act, in particular, using health insurance to address the area that all people in the U.S. in particular didn't have access to help and get the process started in terms of identifying the management team and getting a plan to lower the prevalence of diabetes in certain communities. Thank you, and I'm happy to answer any questions. And I will just note that in figure one, there's a pie chart that may not look too alarming due to the small percentage of the adult population globally that has diabetes compared to the rest of the world. But I will note that it is an issue, a very big issue globally, because it shouldn't be detected at all. So while that's a small piece visually, those are still millions of adults around the world that has this disease, and it's a disease that is preventable in some cases, and health equity would help address a lot of those cases and scenarios. So again, thank you so much, and I'm happy to answer any questions.